My name is Octavio Pontes. I am a neurologist and editor-in-chief of the World Stroke Academy. It is my pleasure to be here with my dear friend Marc Ribo, who is also one of the experts in the field of endovascular therapy for stroke. And Marc, welcome to this interview. It's a pleasure to have you with us today.
Hello, Octavio and everybody. Sure, the pleasure is mine. And here we are to discuss whatever you want.
Okay, yeah, yeah. Well, Marc, as we have been working on the field of stroke for several decades now, that endovascular thrombectomy has revolutionized the treatment of acute ischemic stroke, and we are now advancing, the boundaries of the treatment. And within the last few weeks, Marc, two publications of two randomized controlled trials, the Distal and the Escape MIVO trials, were published in these trials. They brought some I would say some disappointing conclusions about the use of endovascular therapy for distal middle vessel occlusions. So I would like to hear your comments about, first of all, what in your opinion are the main challenges about treating patients with distal vessel occlusion with endovascular therapy?
Yeah, Octavio, I think this is a great opportunity to try to get away from the confusion that was created in the last 2 months. I'm hearing a lot of statements that sometimes make sense, sometimes does not. People ask themselves, so now we should not treat distal occlusions anymore, or now what about the M2s? Are those distal? Are those not distal? Should we just stop that? Are we harming the patients? Are we not? I think, yes, there is a lot of confusion, and these trials will help us to redefine the future indications. But right now, let's try to walk through all these questions that I just raised in order to clarify to people how we should proceed in this interim time.
Exactly, Marc. So first of all, what were your first impression about the results of the trials?
So we were contributing, recruiting in the Distal trial, one of these
Yes.
trials, and with the principal investigators, with Urs and Marios, during the recruitment, we were very worried because we were observing that recruitment was done in a population much older than what we expected and with milder symptoms. And that means that investigators probably they lost the equipoise. We were randomizing patients in which we were not convinced of the treatment, but in those in which we were relatively
Right.
sure that endovascular therapy would work, like younger patients with a distal occlusion but with severe symptoms, those probably were treated outside of the trial. So we end up having a trial of, let's say, older patients in which milder symptoms, finding a treatment effect is going to be more difficult. And therefore, the conclusions of these trials, and I would say it's the same for Escape MIVO, should not be directly applied to all patients with a distal occlusions, especially if they have severe symptoms or if they are younger, right? So this is my first consideration.
Right. Marc, we have within the trials, successful reperfusion rates with thrombectomy were lower than typically seen in large vessel occlusion trials. Do you believe that current devices and techniques are currently adequate to the challenges of the distal vessel navigation, or do we need, technological advance to improve the outcomes of these patients?
So that is another of the questions. We learned the hard way, I would say, that we are probably not as good interventionalists like me, our skills, but also our devices that are available are probably not as good as we thought for these new locations. It is not the same to treat a proximal M1 occlusion in which the artery is not going to move, is not very tortuous, than to treat a very distal M2, M3 through a lot of curves very far away from the base, from the carotid artery, in which we need to navigate. Basically, today we're navigating the miniaturized versions of the same devices.
Right.
And
Right.
maybe this is not the right way to do that.
The
Maybe
right
we
way to
need
do it.
to uh, develop specific devices for these anatomies. Maybe we need to select our patients according to anatomy also,
Right.
because maybe if it's very tortuous, uh, we should use lytics. For smaller clots, lytics should also work better than for bigger clots. So we need to calm down, digest all this data, work on our skills, on our devices, on our techniques, and hopefully come back with equipoise this time and redesign these new trials that will tell us the true answer about the effectiveness of treatment and the vascular treatment of distal occlusions.
All right, Mark. So I mean, just to summarize the point we are right now, right? So what would you say to clinicians at this moment about, treating distal vessel occlusion with endovascular therapy? Should we exercise more restraint and when considering the endovascular indication for this? And also, could you please tell us if there is any subgroup of patients right now that you would persist in and try to treat the patients despite the negative results of the trials?
So yeah, let's try to send a clear message. I think these trials, they didn't show that thrombectomy in distal vessels doesn't work, and we shouldn't do that. No, or it's dangerous. No, this is not. They just showed neutral results in this population that I mentioned. So the message is, right now, when you have a candidate with a distal occlusion, you should not upfront discard it from thrombectomy. You should consider it individually, and especially if the patient is younger, he has a high NIH, or the location is not very far away or tortuous, I would be more prone to treat. But on the
Right.
other hand, I should not feel guilty if this is a patient with an older age, with a difficult access,
Right.
and milder NIH. I should not feel guilty not to perform a thrombectomy,
Right.
because with the evidence today, it's not clear that I will benefit this patient. So I think we are in an interim period in which we need to individualize a lot, and we should still be comfortable doing a thrombectomy if we believe it's the right thing, or not doing it if we believe it is not a good candidate.
All right, Mike. I think in the end, we've been we kind of used to this scenario that sometimes you have some disappointments in the first few trials. That's this almost the same story with large vessel occlusion with the first pivotal trials for thrombectomy. And in the end, sometimes this is helpful to establish some equipoise and to move forward the field with a more more another trials. So probably gonna see more trials in MIVO looking forward, right, Mark?
I know there are several on the way, and in the next months, years, they're going to start. And but meanwhile, I think it is fair to think we forgot the lesson from 2013, as you said.
Right.
And when we participate in a trial, we should keep the equipoise and
Right.
enroll all comers that
Randomize
are
everybody.
candidates. Yeah,
Yes.
all
Yes.
candidates. Otherwise, we get to
A
these
lot of
scenarios in
bias.
which there is a lot of confusion.
Yes. All right, Mark. Thank you so much. Very helpful and very thoughtful as always. I think that we're gonna see a lot of discussion about this looking forward. Thank you so much for your joining us today, Mark.
Thank you, Octavio. See you all.
See you.